I'll wait now that the recording has started. I'm Mike Saag at the University of Alabama at Birmingham, and we're here today for a webinar on palliative care. Our presenter is Dr. Jessica Robinson-Papp, who is a professor of neurology and at the Icahn School of Medicine in Mount Sinai, New York City. It's a very exciting topic today, talking about what is the true meaning of palliative care. Most of us think about that as end of life, and certainly that's a part of it, but in my view, it's as the title says, maximizing function in the setting of some sort of disability, and we're going to focus on the population of HIV patients today. So welcome, everybody. You'll see that demographic questions are flashing in front of you. It's not an end-of-life issue. These are questions that we're just trying to get to see who's in the audience today. It's like the opening line from Hamlet, who's there? And so that's what we're trying to figure out. And it helps us know um, uh, who's here today on the webinar. Right now we got over 50 people. There's be more that I'm sure there's 57 now that have joined us, and we'll keep going with these introductory slides, and I'll turn over to Jessica to walk us through the content today. Next slide. The IAS-USA is put together by a group of volunteer members, professors, and other faculty. You can see them listed here, and they help put this together. Dr. Robinson-Papp, you can see her conflicts of interest here that were just recently updated, and my conflicts of interest here. The planning reviewers have looked over this and have determined that there's no significant conflict of interest with what you're going to hear today. For CME credits, which is a big deal, you get 1.25 CME credits today and 1.25 ABIM maintenance of certification points. There are also the same number of nursing contact hours, hours of pharmacy credit, and then the 0.125 CEUs for pharmacy or pharmacy contact hours, again, 1.25. The IAS-USA funds a lot of our activities from internal funds, but also through grant support from unrestricted educational grants from some pharmaceutical companies that you see listed here, Gilead Sciences, Merck and Company, and ViiV Healthcare. And we're grateful for their contributions. As you've already seen and I've already alluded to, there are poll questions that have come through, and throughout the presentation, you'll hear a couple of other poll questions. Just put the responses in, and they'll record your responses. Questions, we'd like to emphasize that, see there's a chat, but we'd like your questions to come in on that other button at the bottom of your screen that says Q&A. And that comes in to me, and I help coordinate that and get the questions to Dr. Robinson-Papp for her to respond to. And I think we are ready to go. And so Jessica, I'm going to turn this over to you. I'm really looking forward to this. Oh, sorry. Here are the poll results. We have a majority are physicians, and then some pharmacists, nurse practitioners, and other nurses as a majority of a PA, one so far. So, Jessica, I'll let you drive and look forward to your comments.
Fantastic. Thank you so much. And thanks for that kind introduction. I'm really excited to be here today and be presenting this topic on palliative care, focusing on people living with HIV. You already saw my disclosures, so I'll go by that. None of that is relevant to what we're going to be talking about today. And so here are our learning objectives. We want to describe the role of palliative care in improving function and quality of life, focusing on people living with HIV, and then alleviating symptoms is a really important part of palliative care. So we'll talk specifically about a couple of symptoms, really focusing on pain and how we can use different approaches, including the ones listed here, to address those symptoms. So we're going to start out with a pre-test question. There will be 2 questions at the beginning. You'll see your Zoom answers there, and then we'll test them again at the end, and the answers will be presented during the course of the talk. So the first question is, which of the following is a common contributor to poorer quality of life among people with HIV? And you're going to pick just one: pain, higher socioeconomic status, psychosis, engagement in spiritual practice, stress related to high social network density. Okay, most of us said pain. So let's move on to the next one. Pre-test question number 2. Which of the following is part of the Fried frailty phenotype criteria? Cognitive testing, gait speed, serum albumin, polypharmacy, or a depression screener? And again, we're just going to pick one. Okay, most of us said gait speed for this one. Great. So moving ahead. So since we're going to be talking about palliative care today, I thought I'd start out with a definition. And I think a nice practical definition of palliative care is care that is specifically designed to improve quality of life for people with serious illnesses and their care partners. Usually when we talk about palliative care and quality of life, we're talking about health-related quality of life, which is more specifically the effect of individual illnesses and their treatments on quality of life. But you could also think about quality of life more broadly. More specifically, palliative care might include these specific items: symptom management, strategies to maximize function and minimize disability, care coordination and advanced care planning, and also end-of-life care. We're not really going to be talking about end-of-life care so much today because that's going to be addressed in a separate webinar, but it certainly is very important. So if we want to improve quality of life in people living with HIV, then we have to know what might be impeding their quality of life in the first place. And there have been a couple of studies that looked at this. 2 recent studies, one in France and one in Norway, found some similar problems that would be associated with quality of life. So having more medical comorbidities was associated with poorer quality of life, experiencing HIV-related stigma, and having lower income. The findings from the Norway study had some overlaps: older age, unemployment, or disability, and then also comorbidities. There was a 2019 review article that summarized the literature, and you can see some of the things that they found here that contributed to quality of life among people living with HIV: physical manifestations, antiretroviral therapy, psychological well-being, social support systems, coping strategies, spiritual well-being, and the presence of psychiatric comorbidities. So these are all things that we want to think about, when we're designing interventions for helping with quality of life. So we can think about these items that affect quality of life among people living with HIV within the biopsychosocial framework. And so all of these are all of the things that we mentioned on the previous slide. So we have our biological factors here, including age, medical comorbidities, our psychological factors, including mental health, stigma, and coping, and then our social factors here. We're going to talk first about the biological and psychological factors, then talk about their symptom management, and then we'll kind of shift over to this area of the slide, talking more about care and providing that quality improvement care. So what about aging? Well, we all know that aging is a big issue for people living with HIV and their healthcare providers. And we can kind of think about that in 2 ways. One is just the epidemiology of the epidemic. So more and more people are living longer and are having the wonderful opportunity to age. But it means that we're having more people as time goes by heading into these geriatric kind of age brackets. The other idea about aging is sort of biological versus chronologic age. There's been some idea that aging can be accelerated among people living with HIV, probably because of this chronic low level of inflammation that they may experience secondary to chronic viral infection, even if they are suppressed. And there's been some interesting literature about this most recently that showed that most of this accelerated aging seems to occur prior to the initiation of antiretroviral therapy, and then sometimes partially reverses or at least stabilizes. So while it does exist, it's at least reassuring to our patients that it's not something that is ongoing so long as they're well treated. And then we have the accrual of medical comorbidities. So I think those of us who take care of people living with HIV will have heard people say to us stuff like, oh, the HIV is the least of my problems now. I have, my diabetes, I have heart failure, I have all these other things going on. And really the burden of comorbidities is something that is very difficult in the HIV primary care setting to deal with. And we think that mechanistically these comorbidities accrue, at least in part, because of changes in the function of the GI tract that are experienced by people with HIV from the beginning of their illness, where there's compromise of that mucosal barrier, which allows antigenic translocation, and then fuels this kind of chronic low-level inflammatory state that contributes to other inflammatory comorbidities. So here are some data just from two separate studies, and in each of these slides, I have the links to the full text articles here, but just some epidemiologic data about some of the comorbidities that seem to be increased prevalence among people with HIV. In addition to medical comorbidities, there are mental health comorbidities. A lot of these predate the HIV diagnosis and can be a risk factor for acquiring HIV in the first place. But the ones that are common are also the ones that are common in the general population. So depression, extremely common, anxiety disorders, and then a little less common things that are perhaps more serious like bipolar disorder and schizophrenia. A big study looked at about 120,000 people with HIV and found that at least well over half were diagnosed with at least one mental health disorder. And then finally, in that psychological category is this idea of stigma. And we can think about HIV-related stigma, or really any stigma, as being in sort of two general categories: internalized and external stigma. So external stigma is what we perceive as coming from other people, that people are treating us a certain way because of something to do with our identity, in this case being HIV positive. And then internalized stigma is when those thoughts kind of exist in our own minds about ourselves. And this is pretty common among people with HIV, that about 44% in one meta-analysis of people living with HIV perceive some kind of HIV-related stigma. And then over here on the right-hand side of the slide, this is a very large study, almost 14,000 people reporting whether they agree with these statements that are stigmatizing type statements about themselves. So the ones that are milder, like it is difficult for me to tell people about my HIV infection, very prevalent, 65% of respondents endorsed that. And then some of the ones that are a little more severe are less common, but still about a quarter of patients reporting that they feel dirty because of their HIV or sometimes feel worthless. So when I read these things, it makes me feel sad, and it's something kind of humbling to think about, when we are working with our clients and patients. On the plus side, a lot of people have developed very positive coping mechanisms from their experiences of surviving over the years with HIV. One positive coping mechanism is something called meaning making, where people take an event that may have been negative in the first place and try to find some kind of benefit or positive light to it. So maybe, I became HIV positive, but then, I learned about my own strength. I learned about the people who really love me and support me. All of these can be very sort of positive reframes and can be a very positive coping mechanism for HIV and then the related comorbidities that people are dealing with. So we've talked about biological and psychological factors contributing to quality of life. So I'm going to shift and talk about symptom management next. And although the comorbidities that people may experience are very diverse, lots of different kinds of medical diseases, sometimes there are some symptoms that tend to be common to all kinds of different diseases. And these are some of them here that are particularly common among people with HIV. And you can see 5 of them here: pain, fatigue, sleep disturbance, cognitive impairment, and mood disturbance. And you can see as well how all of these different symptoms might interact with one another and potentially exacerbate one another. So for example, if you're in pain, you may not be able to sleep as well. And if you're not sleeping as well, that may contribute to your fatigue, which in turn may limit your ability to cope with pain or do the physical therapy or exercises that you need to do for your pain. So all of these things can be experienced individually, but are often experienced one or more of them together. So I'm going to spend most of the time focusing on pain. It's very, very common in people living with HIV. This is a study we did a number of years ago now, looking at the care practices that focus on HIV in our health system, which is the largest HIV care provider in New York City. And we found that doing a search of our electronic health record showed us that about 40% of our adult people with HIV in the primary care setting had at least one chronic pain diagnosis, and 16% had multiple. These were the most common types of pain. Spinal pain, joint pain, neuropathic pain, and headache were the top 4 kinds of pain that people were experiencing. Now, of course, pain is very common in the general population as well, particularly as we're aging. But there is some indication also that HIV itself might actually exacerbate mechanistically how much pain is perceived. And the process by which that might happen is termed central sensitization, or sometimes now more recently called nociplastic pain. And the idea of that is that when you have a chronic pain condition that might be focal to begin with, for example, peripheral neuropathy, or say like knee osteoarthritis, over time, your central nervous system being inundated with these chronic pain signaling can actually become more sensitized to pain, and it becomes sort of like the volume turned up on pain. Now, there's some evidence that HIV itself can exacerbate these processes. This here was a study done in autopsy specimens from people who had donated, people living with HIV who had donated their tissues to science after they passed away. And this was a study looking at the dorsal horn of the spinal cord, which is where all of our pain, somatosensory pain information comes from the periphery into the spinal cord and then ultimately to the brain. And what they saw here were a couple of changes when they looked at people living with HIV who had experienced chronic pain in their lives versus those who didn't. They found that there was more GP120 expressed in that dorsal horn of the spinal cord, so one of these virally associated proteins that's associated with neurotoxicity. They also found signs of inflammation, higher TNF alpha and IL-1 beta, and then also higher markers of synaptic degeneration, suggesting that the presence of the GP120 was an inflammatory stimulus that was then causing changes within the dorsal horn itself that could have exacerbated pain. So how do we treat pain in our people living with HIV? Well, there are no FDA-approved treatments specifically for pain in HIV. There are some HIV-specific guidelines that are a couple of years old now, and I'll just show that on the next slide. We also make use of guidelines for the general population, and then also for similar conditions. For example, diabetic peripheral neuropathy guidelines may apply to people who have HIV-associated neuropathic pain, and since we don't have guidelines of our own, we often use related guidelines. One thing that's really important when we address chronic pain with our patients is that we know statistically it's very unlikely for someone who's been living with chronic pain to then become pain-free no matter what we do. And in talking to the patient about their pain, it is therefore really important to set realistic goals for treatment. If people are expecting you to make them pain-free, they're going to be disappointed. The flip side of that is that you don't want to be a nocebo. You don't want to be so sort of dark and dismal about the whole thing that people lose hope, because hope is very important for active coping. And that communication skill in managing pain is quite tricky, but is something that, providers who deal with a lot of pain in HIV have tried to perfect over time. And so the two general categories of things that we can offer to our patients are non-pharmacologic and pharmacologic therapies. Here are those guidelines in case people are interested in seeing them. These are the recommendations that were made. Unfortunately, they're mostly considered low quality recommendations because the evidence base is not particularly strong. So let's start with the non-pharmacologic treatments for pain. I like to think of them sort of on a continuum, or two continua, I guess. The more important one, I think, is this sort of passive to active continuum. So passive non-pharmacologic treatments are things that are done to the patient, so like massage or trigger point injections. And then active interventions are the ones where the patient has to participate. So physical therapy, yoga, mindfulness-based stress reduction. And I think the active ones, I mean, they're all good. And a lot of the times the one that we pick is just whatever we happen to have access to in our practice, or we know a provider who can provide that to our patients. But active really has a distinct benefit of helping the patient develop a coping skill, something that they can use to address their pain when it flares up without necessarily popping a pill. So active, it has that benefit. And then we can think about them as sort of on a mainstream to complementary alternative continuum as well. This I think about as being a little bit less important because a lot of the key elements of both sides are the same. We'll see in this sort of right lower box here, a lot of these alternative therapies that may or may not have a lot of evidence for them. The way I kind of consider these things in my patients is to first think about whether I think it's harmful at all. You know, herbs may not be benign, right? We have to look into them. Do they interact with something? But, I had a patient not too long ago come in to my office with neuropathy and say, oh, I got these socks and they have these copper threads in them and they really help my neuropathy. And so, that is going to be extremely low risk. There's basically no risk there. So rather than be like, oh, that's silly, what I said to myself, this is a positive coping mechanism, right? They've done something harmless to themselves that makes themselves feel better. They've probably enacted a placebo response in their own brains, which is amazing and positive. So, I really encourage that patient to continue being proactive in their own pain relief. So I said that there's some common threads about these different treatments, and a lot of them sort of follow this cognitive behavioral therapy type model. And the main points of cognitive behavioral therapy are cognitive restructuring. So that's that reframing of negative thoughts about things, catastrophizing into something more self-efficacious and positive. Teaching people behavioral skills, so skills to manage pain, and also then building those skills. Usually there's some combination of some kind of psychological intervention and then a physical component that might have strength or flexibility or increasing cardiovascular fitness. A lot of the times there's some kind of body awareness technique also. People can be really detached from their bodies when they're living with chronic pain, and then pain self-management techniques. Here's an example of an evidence-based intervention that was developed by my colleague, Jesse Merlin. It's called the STOMP intervention, Skills to Manage Pain. And this was specifically done in two large HIV primary care settings. It was a 12-week self-management program, and they were able to show that people enrolled in STOMP had a meaningful reduction in their pain. So what about pharmacologic options? In general, a guiding principle is that we try to keep this as simple as possible. A lot of our patients have polypharmacy already, but sometimes it is necessary to use different agents from different classes. And here are some of the classes that we use. I'm not going to talk about CGRP-based therapies today. These are very migraine-specific kind of pain medications, but it's important to just be aware of them. They have come out since like 2018, and they can be really efficacious for migraine. But I will talk about some of the others. The gabapentinoids are probably our most commonly used one. We have gabapentin and pregabalin. Overall, they're very safe. They have few drug interactions. We mostly use them for neuropathic pain, but we can also use them more broadly for more diffuse kinds of pain. Gabapentin in particular has the benefit of being quite inexpensive. Side effects can include sedation, weight gain. Every now and again, people will develop lower extremity edema from this. It's not super common, but when it does, we usually have to just continue the medication. And one thing I like about it is it has a very wide dosing range. Some people get by with doses as small as 100 3 times a day, and then you can go up a significant amount from there. Pregabalin is very, very similar. The main benefit to it is that there's twice daily dosing instead of 3 times, but it does sometimes require prior authorization, so it can be a little bit more difficult to get. Then we have our SNRIs, which are serotonin norepinephrine reuptake inhibitors. Venlafaxine, duloxetine, and milnacipran are the 3 of them. Duloxetine is probably the one we use the most commonly. Its trade name is Cymbalta. It can be helpful for multiple types of pain and is FDA approved for the treatment of multiple different types of pain, fibromyalgia, diabetic peripheral neuropathy pain, and chronic low back pain. This tends to be a really good choice in people with comorbid anxiety and depression because it also is FDA approved for those conditions. Nausea is the commonest side effect, and it usually goes away within 1 week. So I always warn my patients about that. And we usually give it in the morning because it's a little bit activating, so we don't want to precipitate any insomnia. Typically, we can start with a 20 to 30 milligram dose to start, just to let people get used to it and make sure that the nausea is not limiting. And then we can increase to 60 milligrams daily, which is the normal dose. This is also nice because it's just once daily. Two other categories are the tricyclics and the muscle relaxants. The tricyclic antidepressants that we use are mainly amitriptyline and nortriptyline. These are very old drugs. They are kind of messy drugs with a lot of off-target effects. And so we're very, very cautious about these in the elderly or medically frail patient population. They're usually not very well tolerated. We want to avoid them in people with heart conditions, any kind of cognitive impairment, BPH. But, in our younger, more robust patients, sometimes they can still be very helpful, particularly if their pain is worse at night and is associated with insomnia, because then we can use the sedating side effect to our advantage. We can usually do this in a single evening dose. It comes as small as 10, and usually 10, 25, 50, something like that at night can be helpful. There are many different muscle relaxants that we use, mostly for musculoskeletal pain. There's no real reason to choose one other than the other, except for maybe they have different kinds of medication interaction effects with other meds. Tizanidine in particular is often used off-label as well for chronic tension type headache. So that can be useful if headache is one of the pain syndromes. There are also topical medications that can be used for pain. This here is a picture of the high-dose capsaicin patch. This one is FDA approved for the treatment of diabetic peripheral neuropathy. It has to be applied in a doctor's office. It's expensive, so accessibility can be an issue. The other topicals are largely over the counter. I really like these in the treatment of my patients with chronic pain. All in all, they're probably not super efficacious, but every now and again, someone will find them really helpful, and they're so safe that it's nice to have that option. Topical diclofenac, which is also called Voltaren, is an NSAID, but it has very little systemic absorption, so it's much safer than giving people oral NSAIDs. And some people find it very therapeutic to have something to rub on a painful body part, and that in and of itself is sort of like a pain self-management, self-soothing kind of action. Okay, a couple of words about our controlled substances, cannabis, and then opioids. So cannabis is the botanical name of a plant, and it can be further classified as either hemp or marijuana, which is really more of a legal definition depending on the level of THC in the plant. So THC is a cannabinoid that is in the plant, and it is the main psychoactive cannabinoid. So if the THC concentration is below a certain threshold set by law, then the plant is called hemp, and it is federally legal. If it is above that level, then it is called marijuana, and it is federally illegal. The legalization of hemp occurred in 2018, and it was intended to allow the production of CBD products, and CBD is another cannabinoid that is non-psychoactive. And that's sort of when, if we all remember, like you started seeing CBD everywhere, like, in water bottles in your local CVS. It was because of this farm bill that came out in 2018. Marijuana is still federally illegal, although states have legalized, and each state has its own special laws. And in general, the federal government has not interfered with state legalization. So here on the top, we have a map. These are always changing. This is relatively recent. But the green states are the ones that have both recreational and medicinal marijuana legalized. The blue ones are the ones that just have medical marijuana, and then the gray ones are the ones that just have whatever's legal at the federal level. This kind of mix-up of different state and federal regulations makes quality control very variable state by state, depending on what the state has done to sort of ensure quality control. And so making general recommendations about this is very difficult. There have been some sort of big overarching documents that are somewhat helpful. So in 2017, the National Academies of Science, Engineering, and Medicine put together a very lengthy monograph about the attempting to summarize the entire medical literature about cannabis. This up here is the highlights from that monograph. And they found good evidence for chemotherapy-induced nausea and vomiting, for chronic pain, for spasticity, particularly in association with multiple sclerosis, but ostensibly that might extend to other conditions. And then that the effects for other conditions did not have great evidence. There was then a more recent systematic review that included a couple of other indications for which the evidence for medical marijuana had grown in the interim. One of those especially being epilepsy, for which cannabidiol has an indication now. NASM then updated with another monograph in 2024 because a lot of things had changed. And the main thing that had changed in the interim is that use, because of all this legalization, use rates had gone up a lot. And within the cannabis industry, the concentration of THC, which is that psychoactive component, had increased a lot. Like they kept breeding the plants to be more and more potent. And so there's concern now that the literature about the safety of cannabis, which is pretty decent, now doesn't really reflect the products that we have, which are very, very much stronger. In addition, we now have the federally legal hemp industry taking CBD out of their hemp products and then converting it through semi-synthetic processes to Delta 9 and Delta 8 THC. This is largely unregulated throughout the country, and there's been significant concern that these products are very concentrated and that they also may not be safe because of things like residual solvents or pesticides being in them. So I will in New York State, where I practice, we have actually a very well-regulated medical marijuana program. So I do encourage my patients to make use of it because at least they know what they're getting. Throughout the country, though, you can typically look at medical marijuana products if you're getting things like CBD online, and look for a certificate of analysis, which will show whether the products have been tested and analyzed to make sure that they contain what they're supposed to. There isn't a lot of general guidance or evidence-based guidance, I should say, on how to recommend this to our patients. So in the absence of sort of good data, in 2021, a group came together to do some consensus recommendations that's based on expert opinion and a Delphi process. This is that article here, which you can reference. And so they gave this sort of general recommendation for a routine titration, starting with CBD, titrating the CBD up. If that's not enough, then adding the THC and titrating the THC up. This was their routine algorithm. And then they also gave one that was more rapid and one that was more conservative. These are recommendations for oral dosing. Oral cannabinoids undergo significant first pass hepatic metabolism, which means that if you bypass that metabolism through other administration routes, then the doses are much, much lower. So those other routes include transmucosal and vapor or inhaled routes. So when we do the oral route, the duration of onset is fairly slow, 1 to 2 hours. So patients really need to be aware of this. Sometimes what happens is people will take something, an hour and a half will go by and they don't feel anything and they say, oh, I need to take some more. And then all of a sudden they have taken too much. So it's important to be very conservative there. Start low, go slow. Duration of action is also the longest with the oral route. Transmucosal is usually some kind of like a dropper or a tincture or a spray that can be put under the tongue or in the side of the cheek. This is sort of an intermediate onset, intermediate duration of action. Patients have to be told not to swallow the liquid, to let it be absorbed in the mouth. Otherwise, you just get an oral kind of metabolism instead of a transmucosal metabolism. We do have good dosing guidelines for transmucosal routes of administration because there's a product called nabiximols or Sativex, which went through a full regulatory pathway and is cleared by regulatory authorities in Canada and in the EU, although not in the US. And so we know what the dosing recommendations are for nabiximols. So by extension, some of the products that we have in the state programs could probably follow a similar dosing. If you're using vapor or an inhaled method, the onset of action is much shorter and the duration of action is also shorter. And the bioavailability is higher than the transmucosal, although the exact ratios are not yet known. So what about opioids? I think many of us will be familiar with the CDC guidelines for opioid prescribing for pain, which came out first in 2017 and then were revised in 2022. Basically, the guidelines are fairly common sense. They urge us to not use opioids as first line for pain and that we should think carefully about weighing the risks and benefits to our patients when we prescribe opioids. But they're not real specific about how to weigh the risks and benefits, and that's because it's not really known how best to do that. But first of all, are there benefits to opioids long term? And the answer is we don't really know. There are many people who are sort of anti-opioid will say, well, there's no evidence that opioids long term are good for chronic pain, which is totally true. But there's also no evidence that anything is really good for long-term chronic pain because our clinical trials for chronic pain are typically 12 weeks long. It's really not possible to have a placebo-controlled trial that goes on and on and on. People just wouldn't do it. But there have been some meta-analyses. This is a very good one back. It's a little old now, but still probably the best one that looked at number needed to treat for various kinds of pain conditions. For tramadol, which is a weak opioid, 4.7. Strong opioids, 4.3 people needed to be treated to have a benefit, which is still probably better than pregabalin and some of the other agents that we have. So then when we think about, if we accept that there may be some benefit for opioids for chronic pain, then let's think about how we might weigh those risks. And when I do this, I like to think about sort of two distinct groups of patients: the opioid naive patients, in which I sort of include people who are not on opioids now, but may have been in the past, and then our legacy patients, the patients who perhaps are coming from another provider or have lost access to their provider who are already on chronic opioid therapy. And the risks, I think, are the same for those two groups of people, but how we weigh them, I think, is different. So the risks are, for example, undertreating pain. The big risk is opioid use disorder. And we think about opioid use disorder using the 3 C's, which is easy to remember for a non-addiction specialist like me: loss of control over the opioid, compulsive use, and then continued use despite harm. And then the third risk, which I think is almost unique to opioids, is that, or other controlled substances also, is that when we're handing someone a prescription, there's also risk to everyone around them. Increasing opioid volume and density in the community is a risk that I think we also have to consider. And so when we weigh these risks and benefits, I do so using a harm reduction approach, thinking, what am I most worried about in this individual patient, and what do I think is the best way of avoiding it? And I think that's different in our opioid naive and legacy patients. In our opioid naive patients, we really do try to avoid opioids at all costs. And then in our legacy patients who are otherwise stable, it may be lower risk to just leave them be and continue their prescriptions. And so we've developed this algorithm, which is what we use in our own clinic. It is not evidence-based. It is sort of expert experience-based, and it's something that we use to try and make sure that we maintain an even-handed and fair approach with all of our patients, and that we maintain our own sanity. So it's really based on urine toxicology. We do our urine toxicology screening, and when you do your UTox, it's very, very important that you understand the limits of the UTox available at your own institution. So, for example, in most urine toxicology screens, oxycodone is different than, say, methadone is different than opiates, and those things will show up separately. So you have to make sure that you understand what your drug should show up as in your urine tox screen. So we start with that. If the prescribed item is not in the urine, then we have a talk about that. Is there a reasonable explanation, like they have only very low dose PRN use? If there's not a reasonable explanation, like they're on OxyContin and they take, they get 15 milligram pills and they get 60 per month, like that substance should be in the urine. And so then we, in our clinic, just stop prescribing at that point, assuming that there's a diversion situation. If the substance is in the urine, then we see, well, are there other substances in the urine? I don't worry too much about marijuana since that is legal in my state. But if there are other things like cocaine, I ask my patients about substance abuse or misuse. If we can have a reasonable, honest conversation about that, I personally will give the person another chance, but make it clear that I'm not going to continue prescribing if there's other substances in the urine. Other providers do this very differently. I think the important thing is just to have a consistent approach. Then I think about, well, are there any behavioral issues in these patients? If not, this is sort of our ideal patient. They seem to be stable. We see them at least every 3 months. That's what the guidelines say, 1 to 3 months. And I do at least, at that quarterly visit, talk about whether they might be willing to do a consensual opioid taper. Some patients are. If there are behavioral problems, then we reinforce our opioid contract. We talk about what the expectations are. We do a verbal contract in our clinic because I don't believe that people really read things if you put them in front of them. but we have a conversation instead. And then if this continues to be a behavioral problem, then we have to address that. One thing we do use a fair amount of now is buprenorphine, and I'm not going to have time to go into the details of this, but there are several forms of buprenorphine available, some of which are FDA approved for the treatment of chronic pain, and some of which are FDA approved for the treatment of opioid use disorder. But we can, as physicians, decide to use things in an off-label fashion. It is a good pain treatment, obviously much safer than full mu agonists, and you don't need any kind of a waiver anymore to prescribe buprenorphine. You never did if you were doing it for pain, but you don't need to make that distinction now between pain and opioid use disorder. So I'm going to move very briefly through some of the other symptoms that tend not to have so much of a specific management plan. Fatigue, I think, is a really fascinating symptom. It's been conceptualized, or the perception of fatigue is conceptualized as a detection of a mismatch between our own energetic state as it is and how we conceptualize it in our mind as it should be, our homeostatic ideal. And there could be a couple of different reasons why that is. We could have bodily fatigue due to high energy demands in the body, like if we're sick for some reason, we have acute illness, or there's poor energy reserves or utilization in the body because of nutrition or deconditioning. We can also have mental fatigue, which may be because of high cognitive demands or inefficient processing due to neurologic or psychiatric disease. And then there may be a problem with our homeostatic ideal, like maybe we just think that we should feel better and stronger than is realistic to feel. And so those are things that can be explored with the patient. There's no specific treatment for fatigue. If we can find causes of it, of course, those would be treated. But a concept here is the idea of pacing, which is also important for people with chronic pain, which often overlaps with chronic fatigue. So a lot of these symptoms are variable. So some days will be good days, some days will be bad days. And when patients have a good day where they're not super fatigued and they don't have a lot of chronic pain, some people will want to go out and get all their chores done and do a lot of stuff. And then they'll do too much. And then the next couple of days, they'll be completely wiped out. And that can be a very vicious cycle that ultimately worsens deconditioning. So we do want to advise patients to try to pace themselves. Like if they're feeling really great, that's awesome, but just try and do a reasonable amount of activity and not overdo it. If there are days that they're feeling really bad, still try to get up and do something, at least something minimal to maintain that conditioning. What about sleep management? So there are a lot of potential underlying mechanisms by which HIV infection itself might contribute to poor sleep. So I refer you to these articles down here. I'm not going to go through the details of this picture, which was taken from one of them. So there are like very physical mechanisms by which sleep could be disruptive. And then there are also complex biopsychosocial factors that a lot of our patients are dealing with. In my clinical practice, a lot of our patients are living up in Harlem. They don't have maybe the nicest living conditions. There may be a lot of noise. They may have a lot of people in their apartments, lack of privacy, lack of feeling safe in the home. All of those things can potentially interfere with sleep. In 2023, there was a systematic review of non-pharmacologic interventions for sleep among people living with HIV. And you can see some of the interventions that was studied there, things like CBT, sleep hygiene, mindfulness, et cetera. Finally, the last symptom I'll touch on is cognition. So cognitive impairment can be due to a number of things. When it's due to HIV itself, we call it HIV-associated neurocognitive disorder, or HAND, although there's been a recent working group that has suggested this sort of new title, HIV-associated brain injury, or HABI. There is legacy effect. So HIV gets into the brain shortly after infection, and so there may be an active inflammation in the brain before people get on antiretroviral therapy. And then so that may be active and ongoing, or it may just be a legacy effect from the past. And then there are other things to think about. People, may have had CNS infections. They may have had a history of head trauma, substance use, things of that nature. There's not a lot we can do to treat it, to treat HAND specifically, other than, making sure people are on their antiretrovirals. But there is some interest in this sort of like cognitive rehabilitation, which usually has two general kinds of approaches. One is this idea of kind of supporting the patient and seeing what their weaknesses are and giving them strategies to address those specific weaknesses. And then another approach is to drill and practice kind of doing like mind puzzles and kind of trying to get faster at that sort of thing. So both of those things can be tried with the help of a therapist or can be used together. So hopefully you've seen kind of through some of these symptoms and interventions that some of the things that we can do, like CBT, might cross diagnoses, right? They might be good for multiple different kinds of symptoms. And so this has been addressed a little bit in a couple of studies. This is one of the studies that came out recently by Lisa Ubelacker and colleagues in just last year. She developed an intervention called HIV pain and sadness support, or HIV PASS, which was designed to treat both pain and depression at the same time. This is kind of reminiscent also of the STOMP intervention that I mentioned before. It was multiple sessions. It had an educational component and a coaching component, pacing, and then also, attention to meaningful activities. And they found that the intervention was effective in reducing pain-related interference at the end of 3 months. Unfortunately, once the intervention was stopped, they followed the people out further in time and found that the effect of the intervention was not sustained. And so it really was only working so long as people were actively involved in it. So that limits a little bit. It's not too surprising, but it does make you think about how you might be able to implement something like that in real-world clinical practice. There's a recent meta-analysis or systematic review of different exercise interventions. Overall, these were found to be helpful in multiple domains of health-related quality of life, which are listed here at the bottom of this slide. They looked at both aerobic exercises and then combined aerobic and resistance exercises and found that the combination overall seemed a little bit more effective than aerobic exercise alone, although any exercise should be encouraged. And then specifically with regards to CBT, there was a very recent systematic review that demonstrated the efficacy of CBT in improving antiretroviral adherence, particularly in those with psychiatric comorbidities. And then there was another study, which I thought was pretty interesting, where they used CBT, again, for like a transdiagnostic kind of treatment across multiple symptoms. In this case, they were looking at depression, anxiety, and health-related quality of life in this particular intervention. So CBT is something that certainly can be very helpful, very, very hard to get in, and I'm acutely aware of that in clinical practice. It's not something that's easy for us to get our hands on, and we're a very large HIV-focused primary care clinic. So that is, of course, frustrating. Okay. So we're going to move over into this sort of lower right-hand quadrant of the slide, talking about social factors and then care coordination and planning. So social factors, I think we all are very aware that lower socioeconomic status is common in people living with HIV. If you look at maps that look at HIV prevalence and the percent of the population in that same area who live in poverty, those things tend to overlap. And then even among people with HIV, lower socioeconomic status is associated with multiple negative outcomes and sometimes may limit access to care. Social isolation and loneliness is also a big issue in our patients. And these are related ideas, but not exactly the same. So social isolation specifically refers to how many contacts with different people or different groups of people one has in their life, whereas loneliness is sort of the feeling of being lonely. This was a study of people living with HIV seeking to quantify the amount of loneliness and isolation they experienced. And they found that about 46% of patients were neither isolated nor lonely, 15% were both, and then 26% were lonely but not isolated, and then 12% were isolated but not lonely. So still a greater than half experienced, either or both of these symptoms. So how do we put all of this together and develop a palliative care type model for people living with HIV? So I said in the beginning that palliative care is really about maximizing quality of life and coping with serious and debilitating illness. And a lot of people who are specifically palliative care trained don't spend a lot of time actually addressing the illness at hand, right? Like their job is to manage the symptoms, not to treat the underlying thing. But in the HIV care setting, a lot of us try to focus on being very holistic for our patients and giving them as much one-stop shopping as we can. And for that, I think I actually like a geriatric care model even better than a palliative care model, because that's what geriatric care also focuses on. They do chronic disease management, they focus on addressing and minimizing polypharmacy, which is certainly relevant to our patients, enhancing function and maximizing independence as people age. But before we can even use any model, I just want to pause and acknowledge that there are a lot of barriers to getting our patients even in the front door. Here are a couple of them that appear in the literature. This is a qualitative article, so they interviewed people living with HIV about their care. And I just found this really a poignant statement, and something that I think rings true is that sometimes the clinic itself can be triggering to people. Like, it's just a place that reminds them about their disease that they, may feel very stigmatized about, regardless of how kind and welcoming we might be as providers. So geriatric care begins with a comprehensive assessment. Oftentimes, there will be a comprehensive medical history, which specifically goes into patient functioning and their ability to perform their ADLs. Sometimes standardized questionnaires can be helpful for this, and functional assessments, things like timed up and go, a 2-minute walk test, or assessments of hand grip strength. We may do frailty assessments. A big part of it is medication reconciliation, going through sometimes people's very long lists in our electronic health record. What are you still taking? What do you need to be taking? What could we potentially get rid of? And then this idea of advanced care planning. Here is one example of a way of assessing frailty, which is the Fried frailty phenotype criteria. It includes weight loss, gait speed, grip strength, and physical exhaustion, and then low energy expenditure. This is measured by a questionnaire that asks people like how often they do different tasks during the week, like laundry, going up and downstairs, things like that, and then can translate that into a higher or lower energy expenditure. There are recommendations. This is not specifically, by the way, for people living with HIV, but these are general recommendations of things that should be offered to people who are indeed frail, and up to 28% of older people with HIV meet this criteria. So things like offering a multi-component physical activity program, being careful about aggressive or hospital level care, because people may be more at risk for hospital acquired conditions. And then polypharmacy. This is a recent article from 2021 that looked at all of the different kinds of the most common basic medications that are used among our people with HIV, other than the antiretrovirals themselves. And we know that since patients have already the antiretrovirals that they have to take, they are more likely to be exposed to polypharmacy at a younger age. At that, over time, many patients have increasing polypharmacy over time, although some do not. So finally, what about advanced care planning? So advanced care planning is the process of identifying wishes for future care in the event that the patient has a serious illness and isn't really able to make those wishes known to their providers. And it should be very patient-centric and based on that patient's individual values. Usually it involves appointing a surrogate decision maker and involving that person in the discussion with the patient and the provider, understanding what the wishes are and what the decision should be. This can be formally documented in an advance directive. Relatively few people with HIV have advanced directives, according to the literature. This could be related to social isolation, possibly lower health literacy. Healthcare provider time constraints are also a tremendous barrier that ought to be acknowledged. In our clinic, our primary care providers dealing with complicated people living with HIV as clients get 20 minutes for their primary care appointment, which is extraordinarily challenging. There has been some research into advanced care planning for people living with HIV specifically. One particular model was the family-centered advanced care planning model, or FACE. This was developed via a community-based participatory research approach, and it outlined a two-session approach, where the first session would be talking about choices and goals, and then the second session is really defining those goals using a 5 wishes advanced directive algorithm. So in summary, broadly, the goal of palliative care is to improve quality of life. We can use different care models to do so. With the palliative care model, including things like symptom management, strategies to maximize function and minimize disability, care coordination, advanced care planning, and end-of-life care. And the geriatric model also including management of the underlying diseases themselves. General detractors from quality of life among people living with HIV include aging, comorbidities, stigma, socioeconomic issues, and lack of social support and loneliness. So these are things that might be particularly targeted by palliative care and geriatric approaches. And the contributory symptoms that may adversely impact quality of life and may be due to multiple different diseases and are not disease specific are pain, fatigue, sleep disturbance, cognitive impairment, and mood disturbances. And these symptoms often can be overlapping and interacting and exacerbating one another. Okay, so we're at the end. So we're going to come back to our post-test questions. Post-test question number 1, which of the following is a common contributor to poorer quality of life among people with HIV? Okay, we've all said pain. That's good. Yes, pain is the right answer. Common contributors to poor quality of life that we talked about were pain, fatigue, mood disturbance, sleep disturbance, and cognitive impairment. Socioeconomic status certainly contributes, but higher socioeconomic status would ostensibly be better. Psychosis can occur. We had that in the slide about mental health comorbidities, but it's relatively uncommon. Isolation and low social network density is a more common problem than people being overly social and getting stressed out about their social responsibilities. Okay, question number 2. Which of the following is part of the Fried frailty phenotype criteria? Cognitive testing, gait speed, serum albumin, polypharmacy, or a depression screener? Okay, most of us said gait speed, and that is correct. So the components of the Fried frailty phenotype criteria are weight loss, gait speed, grip strength, physical exhaustion, and low energy expenditure. All the other things in that list may also be very important and could play an important role in a comprehensive geriatric assessment, but they are just not specifically part of this phenotype. And with that, I will stop sharing my screen.
Just fabulous. I mean, very comprehensive, covered common things that we see every day in all of our clinics. And I think the Ryan White clinics, a lot of the folks I see in the group participate in those, make it a bit easier to access a lot of these components. If you're a solo practitioner just slugging at this every day, it's kind of hard to address them all, but it's really it's very comprehensive. We have a couple questions. I'll go to those first, and then I have a couple follow-ups personally. But this is from John Weiser at Grady in Atlanta. It's more of a comment than a question, but the principles of palliative care you describe should be the foundation of all medical care. Clinicians in all area of medicine are subject to seeing patients through the lens of disease rather than the whole person. Atul Gawande, Being Mortal, is a good read. I don't know if you want to plug the book, but I mean, I think, how can you argue with that comment?
No, you can't. And I think it's so important. And I think especially like I'm a neurologist. I don't know if I probably didn't mention that, but
Yeah.
and I take care of mostly people with HIV, and just I can't even begin to understand like what they're trying to tell me, what they're trying to convey about their illness until I understand them as a person, really, because oftentimes neurologic symptoms come through as being a little bit chaotic, a little bit vague, And I really do need to understand that whole person and how it fits into their experience. And so I completely agree that it has to be about the holistic um, person. And I think what's also humbling and also helpful in a way is for us to be kind to ourselves and understand that so much of health happens outside of the clinic and outside of things that we can control as providers. Um, so while we can look to those things and try to encourage our patients to have positive and healthy lifestyle choices, so much is out of our control. And I think accepting that as a young doctor was something that, made my life a little bit easier.
Yeah, yeah, can't argue with that. Um, Kevin Carmichael in Tucson says, thanks for an excellent presentation. Can you comment on the recent suggestions that gabapentin may have an association with dementia? And that fits right in your wheelhouse of being a neurologist.
Yeah. So, I mean, it I think it's a harm reduction kind of approach. And in our patients with HIV, it's understanding what is impacting their cognition at any one time is extraordinarily difficult. So usually when I have somebody with a cognitive complaint, it will probably be some combination of, longstanding HIV that was probably untreated for a while back in the day, aging, some head trauma, some substance use, some low premorbid functioning, and then perhaps aging. And now I have a few that I actually do think have Alzheimer's type dementias. So I think in the scope of all that, I do not think of gabapentin as being a meaningful contribution to that risk. Um, and I also think of gabapentin as being one of the very safest options that I have for treating pain. Um, so I don't personally spend a lot of time thinking about that.
Yeah, I mean, there's a little bit of a sedating component to it, and maybe that interferes with cognition a little bit, but that's true with a lot of medicines that we use, especially if we're addressing pain. And it's probably a whole lot less than opioid impact or benzos,
Yes.
which cause amnesia. Um, okay, Sylvia Oliveira, Oliveira, sorry. Do we have further data on the prevalence of chronic pain, more severe in people living with HIV and using substances, more illegal or on the street substances, and other populations um, who might not be living with HIV?
Yeah, that's a great question. Um, finding, and it's hard epidemiologic work to do because our people living with HIV are often more medically complicated than their age-matched peers. So it won't just be the HIV, it will be, other medical comorbidities, which all can contribute to pain. There is an interesting study. I think Carolyn Sabine is the first author from the UK that looks at a well-matched aging population and does find increased pain prevalence in people living with HIV. But you have to decide how to control for it. Like, do you want to try to keep the other comorbidities pretty constant, or do you want to like kind of look at a very healthy elderly population? So I think there probably are more. There is certainly also data that substance use disorders and chronic pain overlap. So people with substance use disorders are much more likely to also have chronic pain disorders. That's not to say that all people with chronic pain have substance use disorders. It doesn't kind of go the other way. But chronic pain is very common in substance use.
Okay. Um, we have a question from iPad number 5. How well does Effexor work compared to Dulux, or is it more weight neutral?
Yeah, that's a great question. So Effexor, which is venlafaxine, is one of the SNRIs that I mentioned. It has more S than N, so it's really closer. It's closer to an SSRI than an SNRI, although it does have some norepinephrine effect. There aren't any comparative studies like to actually answer that question in a really scientific way. Um, a lot of pain medicine is sort of anecdotal and a little bit like lore. We believe as neurologists that Effexor is good for headaches. And there actually is, I think, like a level B recommendation from the American Academy of Neurology for that. So it can be really good if somebody has comorbid migraine. So we use it for that. It's not usually like my first go-to for like bodily pain, though.
Yeah, and while we're on that topic, you nicely talked about sleep, which is a big focus of what I do a lot of my practice, especially people with chronic pain. The analogy that I usually flash to is I asked them when they were a kid, 9 years old, they spent the night at a friend's house. Did they ever stay up all night? And of course, most people had that experience. And then I say, how'd you feel the next day? Right? And if you have not just one night, but weeks worth of one nights like that,
Yeah.
there's no way you're going to feel well and have good well-being. And I think it aggravates pain. So coming then to address sleep, um, you mentioned the tricyclics. I've used a lot of trazodone to try to
Mhm.
help with sleep. What is that a go-to drug for you? I kind of like it because it's not habit forming and you can adjust the dose, sort of like gabapentin. But what do you like to use?
Yeah. I usually don't treat sleep primarily. Like our mental health providers will do it, but trazodone is certainly something that they use very commonly.
Yeah,
Yeah,
I think the concept is it's hard to address a lot of these things, especially fatigue and pain, unless you get sleep fixed. And the other
absolutely.
Yeah, and the other comment is that there is, at least in our clinic, and it may be that I live in the South, but there is a boatload of untreated obstructive sleep apnea. And CPAP machines can do wonders for people if they can tolerate it and use it well.
Yeah, we see a lot of that as well. That comes to neurology as headaches in the morning.
Ah, there you go. Interesting. Um, John uh, Weiser at Emory Grady had a follow-up, a different question. What are the elements of your verbal pain management agreement for patients prescribed chronic opioids? Some of us, like we have a written, but you do it verbally. What do you like to
I
include in?
do. So I do it verbally, but I also have like a smart phrase in Epic so that I pull it up so I can like look at it and make sure I'm hitting the points that I need to hit. So the first one is you must be seen in clinic monthly to start. The very reliable people who have had forever, they can go out to 3 months, but no more than 3 months. And so you as the patient it's your responsibility to make sure that you get that appointment because appointments go quick. And if you don't get on it, like I can't overbook you to make up for the fact that you didn't come. You cannot be late. Like there's a 15-minute grace period. After that, it's not like I can't do anything about it. I have someone else coming in. Um, UTOX has to be done at least once a year. Sometimes, we may do it more frequently. Um, then there's a whole conversation about opioid stewardship. So this is a lethal substance. You are tolerant to it. If I took this pill, this 30 milligrams of oxycodone, I would probably stop breathing and I might die. Like you can't give it to someone else. It is your job to take responsibility for it. Then we have to do naloxone is required once a year. So we do, a naloxone training show them how to use the little nasal spray. Um, I think though, no alcohol, no drugs. I think those are the main ones.
Yeah, and agree to a urine drug screen
Yeah.
when asked something else.
That's
Um,
why I have that. That's why I need my smart phrase.
yeah. Well, that's good. You're totally that's why it's there. Um, iPad 5 is back with a question. You didn't mention tramadol much. Back in the day, it was quite viewed as quite benign, but now, as there's more experience, it's viewed more as oxy in terms of harm. Do you use that for chronic pain very much, or does that fall into the general opioid bucket?
No, I actually agree with that sentiment a lot. Like it's a weak opioid. It has also some probably a little bit of like SNRI kind of overlap. So there's some idea, again, it's kind of lower, but that it might be especially good for like nerve type pain. And the abuse potential is in my opinion significantly lower than like an oxy or morphine. So I do use a fair amount of tramadol, but I still do like sort of all the same opioid stuff anyway, like the agreement and things.
We only have a few minutes left. I had a couple quick hitters here that I wrote down. One, I just want to triple emphasize the importance of physical therapy.
Absolutely.
It's amazing how effective that is for lower back pain, much better than opioids. A little bit of nonsteroidal, maybe a Medrol dose pack periodically if there's acute flare. But physical therapy does wonders for the majority of people. So that we should have high on our list, and you emphasize that. Um, I was curious about for those who don't live in one of the states that have recreational cannabis. Um, there's some concern about getting cannabis off the street. Sometimes it's laced with fentanyl, that type
Yep.
of thing. I know you're in a state that has it legal, but just next to you, Pennsylvania, not so much. What can you do? Are fentanyl strips, or is that can you use that in?
I don't,
I don't
I'm
know.
not sure how you would use that with cannabis. I mean,
Yeah.
it's very concerning. And it's still concerning for my patients because even though we have it, it's expensive. So the stuff on the street is much cheaper. So a lot
Yep.
of the times they can't afford the stuff in the dispensary anyway. And so they're still going to the stuff on the street. And you worry about fentanyl, you worry about also like all these like fake weed kind of things like K2
Mm.
spice, like all these weird chemicals that people put on either cannabis or tobacco like products for smoking that are really like overtly neurotoxic. Like we've had crazy epidemics of these in Harlem where there are people just like walking around looking like zombies. It's horrible.
Right.
And you can't test for that at all because it's constantly changing. So
Yeah.
I don't know that you can use a fentanyl test strip on cannabis.
I don't think I haven't heard of that. I just wondered out loud. But one thing that's not a bad idea, it's harmless to have it, is just as give them some naloxone just to make sure that in case something bad happens, people around them know to give that a try. Um, my final question is, I'd never heard the term of chunking. You had it was a small part of your slide, but it jumped out at me. It was in the neurocog section, and it
Yep,
said
yep, yep.
internal, and I thought, what the heck is chunking?
So it's like bundling tasks into like chunks.
Oh,
So sort of like, I have to do these things and then I'm going to do these things instead of like it being like eight separate things. It's like maybe
it's
like,
sequential follow in
yeah,
order.
sort of like an organizational method.
Okay, good. Well,
Nothing
sadly,
super exciting.
sadly, we're out of time, but this has been fabulous. I mean, just covered a waterfront. The good news is that within 24 hours, this will be up and available on the IAS-USA website, certainly within 48 because we have a Friday coming up. But if you have friends or colleagues that you'd like to reference this uh, incredible webinar to, it'll be up and running, and we have a lot of that's one of the huge advantages of these webinars. We have a lot of post-presentation access and use that I think a lot of people can find benefit. For those of you who are on the call or the webinar today, you can get your CME and pharmacy, nursing, pharmacotherapy credits and then a certificate. They'll be emailed by 5 p.m. You've got to claim this on the website. And and that's an important thing. Your feedback is important because we use that to not only assess how well this one went, but put in your ideas about what else you'd like to hear us address. There's a podcast that I host, self-plugging here, sorry, but it's a podcast called Going Antiviral. And one that just came out was with Dr. Carlos Del Rio on providing healthcare to foreign-born and hard-to-reach individuals, which has become even more challenging with some of the changes in how ICE is being implemented in the United States. There's also a webinar coming up with Dr. Rafi Landovitz. It's going to be a case-based approach to PrEP, and that'll include all the newer modalities. And importantly, for those of us in the field, but especially those of us at UAB, we lost a very close colleague of ours, Dr. Letitia Lopre, who died suddenly and unexpectedly at age 43 while working out, and it's a huge loss, and that's dedicated to her. We also have another webinar where Melanie Thompson will be talking about routine and special immunizations for people with HIV, and that's just very practical. A new thing that IAS-USA is getting into is bacteriophages. Remember that it's the International Antiviral Society, so phages are viruses, and they can be used to treat difficult to manage bacterial infections that have developed polydrug resistance. And if you have interest in this, it's a more of a research focused meeting that'll be given very soon in October. And then medical management of people with HIV as they age, a course for non-geriatricians. We certainly touched on a lot of those issues today for obvious reasons, but this virtual course will be chaired by Dr. Roger Badimo and Christine Erlandson. There's a great group of speakers here, and the topics you can see listed in front of you. But that's just after World AIDS Day in December. Thank you so much for participating. Thank you, Dr. Robinson-Papp, for an incredibly comprehensive and practical review of palliative care and HIV medicine. Very helpful to all of us. So we'll sign off at this point. Thank you for participating.
Thank you so much. Bye-bye.